Good afternoon. Welcome to the TK Alexander Memorial Oration. The KSOS President Dr. Mahesh is chairing the session. I'll first introduce Mr. TK Alexander. It's a named oration and it's the most important award of KSOS. Sri TK Alexander was a planter, an industrialist, a right reformist, a social worker and an author, and he was well known in the political circles and in plantation industry. Please don't misunderstand that TK Alexander was a doctor or an ophthalmologist. He was not one, but he has an illustrious son, that is Dr. T.A. Alexander, the senior ophthalmologist in Cochin and past president of KSOS. Dr. Alexander instituted this award in his father's name, and Dr. Alexander and his family thanks KSOS for instituting the oration in this name. This year, the TK Alexander Memorial Oration is awarded to Dr. RadhaRamanan, which was presented at the inaugural function yesterday. It's over to Dr. Mahesh for introducing the orator.
It is my pleasure to introduce TK Alexander Oration Award winner 2024, Dr. RadhaRamanan. Dr. RadhaRamanan was born in 1964. He is married to Rani Sridharan and he is currently the medical director of Eye Vision Eye Care Center, Chalakudi. He did MBBS from Trivandrum, 1983 batch, then DO from KMC Mangalore and DNB from LF. And all this is his professional experience, and one that is in bold, LF Hospital, Angamali, from 1996 till 2013 in different posts, and after that he had been in Eye Vision, Chalakudi, and he had trained lot of doctors in Kerala, in cataract, glaucoma and community ophthalmology. He is a guide to DNB postgraduate students, and he has presented and published more than 45 articles in state, national and international conferences. He had won Shankar Menon Award in KSOS, Best Free Paper Award in Community Ophthalmology Society of India annual meet in Delhi in 2006. Dr. J.C. Kandra and Srimati Sarla Devi Memorial ACOIN Award in 2011. Then he had been an organizational man, and he is part of IMA and KSOS for the past 2 or 3 decades. He has been the website editor, treasurer, general secretary and president of KSOS, and he was the managing committee member of KSOS in All India Ophthalmological Society 2023. He was the treasurer of organizing committee of annual meet of AOC 2023 in Cochin. Present post, he is working as a medical director, Eye Vision Eye Care Center, president, and is a member of Civil Defense and Fire Force in Chalakudi. Lot of community activities he is doing, and that is his highlight, community medical activities. Personally attended more than 1,000 camps from Kasaragod to Trivandrum, and lot of work has been done in disseminating eye care in areas like Lakshadweep and around areas in Chalakudi. And he has been part of cornea transplant trust for cornea transplant motivation, eye donation motivation, and participation in first aid treatment training in Chalakudi area for Fire Force and other organizations. That is Dr. RadhaRamanan for you, and an excellent academician, an organizational man, and a familiar face in KSOS continuously for the past 3 decades. Dr. RadhaRamanan.
I would request the KSOS President Dr. Mahesh to adorn Dr. RadhaRamanan with a shawl.
I am so honored today because I worked in KSOS for so many years. So this is the highest honor I am receiving from KSOS. So for this thing, I thank the whole KSOS, especially the immediate past president, Dr. Thomas Cherian, the president, Dr. Mahesh, Secretary Biju, Scientific Committee Chairman Bastian, the whole executive and the whole KSOS and dear friends. Already Dr. Thomas has introduced the oration, so it is so happy to get this oration, the TK Alexander oration. I am so happy that it was introduced by our own past president, Dr. T.A. Alexander sir. So thank you, sir. First, when you start, I have to thank my subject. Because of this subject, I am here. Once I thank my subject, I have to thank my patients. So I thank all my patients in all these years. Then come to my guru, Dr. Tony Fernandez. He not only taught me the subject of ophthalmology, but he also taught me how to consider a patient, how you deal with a patient, how to be with a patient. And the community services also, you know that he is the pioneer in Kerala. And also I have to thank my Gurukulam, that is the LF Hospital Angamali. Then I have to thank all my teachers, Dr. Epan sir. When you say sir, that means Epan sir in LF Hospital. So he was with me not only as a teacher in all my difficult situations. So all respect to Epan sir. When I joined, Itera sir was my HOD and he was my guide. Even I did my thesis on CSR, so he was my guide. Then Mani sir, more than a teacher, he was used to be a friend. So he used to help me in every situation. And above all this thing, I have to mention about my mentor, Dr. Noel Moniz. I never called him sir, because the first day he called me and told me, never call me sir. You only obey my orders inside the hospital, not outside the hospital. So he taught me from ophthalmology, not only glaucoma, cataract, corneal transplant, even retina he taught me. And because of him I am in KSOS, because he is the person who brought me to KSOS. And when I joined, he was the head of the community services. So he also, so pranam to Dr. Noel. Then all my friends and colleagues in LF Hospital, I think Dr. Andrews, Dr. Elizabeth, Dr. Thomas, Dr. Meena, Dr. Anita, Dr. Girija, all my friends, thanks to all of you. And the present family of iVision Chalakudi, I thank all my iVision family members. Then I will come to my subject today, the community ophthalmology scenario in Kerala. I was thinking about what subject I should select. First I thought about selecting glaucoma, then I thought about selecting SICS. Then few of my colleagues and seniors advised me to select community ophthalmology, because I think this is not presented in the recent years, and also it is near to my heart. So in this presentation I will divide it into few parts. Our camp experiences, a Kudumbasri model, and 3 studies, because of community ophthalmology I have to go to the studies, then only I can tell about the scenario here. Epidemiology of glaucoma, National Blindness and Visual Impairment Survey, and Lakshadweep Ravi study. Lakshadweep is another area very close to us. How to go in community services in the future. So this is the year 1990 when I started my eye camps. The first picture you can see Dr. Andrews also sitting, young Dr. Andrews. Then this was a camp near Bakel Fort. That time we used to go from there to Kanyakumari, and you can see Dr. Mani, all that thing in the camp. And I am happy that I have completed more than 1000 camps, 1038 camps. So it's a happy moment because I could do it. This is personally attending camps, not organizing thing. And this is the last camp, this month camp, still going. Only difference is loss of hairs and baldness, but instruments level and all is changed. Then come to the history of eye camps in Kerala. Actually, the government hospital started eye camps early days. Then it was the era of Murugappa, Channaveerappa Modi, MC Modi camps. He performed, this is from Wikipedia, actually there are different data available, 6,10,000 plus operations up to the February 1993, including all southern India states. He is supposed to study DAM from Kanganwadi Ayurveda College, Karnataka. So that means he is not a qualified surgeon. But still he holds a record of Guinness record of 833 cataracts operations in one day. These operations were conducted in Tirupati in 1968. Whether we accept it or not, he is holding the record, and he got Padma Shri and Padma Bhushan. Come to the LF scenario. You can see young Dr. Tony sir and Itera sir. They are started in 1971. Outside camps, they started in 1971, still going actively in all over Kerala and some outside areas. We conducted from Kasaragod, Mettupalayam, even in some of the Tamil Nadu areas. All these camps, initially Dr. Tony sir was attending, then he and Dr. Noel Monis was instrumental in all these camps and guiding us all these years. Then presently I am doing camps on eye vision. What I am telling is this is a scenario which happens all over Kerala. This is just an representation is LF and eye vision, I just told you. This is one of the camp we conducted in High Court. We have conducted in the very rural area as well as in big towns. And I have to specially mention about a few camps. These camps were different because these camps were, Lakshadweep camps were operating camps. It is one of the most remote place in India, and really requires camps there. That time it was only one eye ophthalmic facility at Kavarati. And this camp procedure was initiated by Dr. E.J. Mani and Dr. Hamsakoya. I think he was here. That time he was the Director of Health Services in Lakshadweep. We continued the camp up to 2018. Now the happy thing is there is very good facility at Kavarati, and Dr. B is doing excellent work at Kavarati. You can see, I think, Dr. Manisar, Dr. Amsakoya, you can see that Dr. Rachel Madam also in there. She also attended eye camps along with us there. She was the Deputy Director of Health Service at that time, and we used to operate it in the Kavarati hospital. Actually, I had a lot of people, I think, present here also accompanied me with Manisar at different eye camps in Kavarati and other Lakshadweep islands. This is one photograph I never used to forget, because we used to visit different islands, sometime through helicopter and sometime by boats. This picture you can see Dr. Rachel Madam, Manisar and all smiling. Why this smiling is so important is, we traveled to another island, and when we are coming back the sea got worse, so horrifying, and finally we nearly reached the land. So that time we took this photo. It was a different experience, so everyone was so relieved, because we have faced a lot of problems also during these camps. This is a hospital scenes from the Lakshadweep area. Now we are doing camps in different parts. In I-Vision, we are doing it near Chalakudi and all. But the difference you can see that from earlier torchlights, we are into the portable slit lamp or slit lamps and to portable auto-refractometers thanks to Oro Lab people. Then actually the scenario is little changing now. From the cataract, we are going to the different diseases. To diabetic retinopathy, glaucoma, all other diseases we are doing. So during these camp days, we were thinking how to improve the quality of eye camps. As I mentioned, people are using high-tech instruments in this thing, and mobile eye camps are used in different mobile vehicles are available in government sector as well as in the private sector. So the quality of eye camps in Kerala has remarkably changed. School screening programs are more systematic now with the tracking of good defaulters. Ophthalmic awareness programs are conducted with the camps, and as I mentioned, diabetic and glaucoma screening also organized. But the main problem with this thing is you will be spending a lot of money, a lot of effort, but the acceptance is sometimes very less. So how we will increase the acceptance rate? That is what we were thinking in between. So we thought about, this is few years back, 15 years back, we thought about a Kudumbasri participation in all these camps. And this paper I have presented in the Delhi Community Services Conference and got the best paper award for this also. That is good. So you know that what is Kudumbasri? This is a self-help group. This is formed as a part of strengthening of Panchayati Raj institutions. So 9 to 12 members will be there. They are from the population, so they know how to work in the population, and they continues to work even after the camps. So the good thing is, initially we used to train them how to detect defective vision, how to detect the people, how to motivate the people, and they will identify the vision, people with the low vision, and they will bring the patients to the camp. And follow-up also, they will be helping us, and these people remains in the community so that it will be, even after the camp, some work will be continuing. Why Kudumbasri is as I mentioned earlier, the effectiveness of the camps. When you are going there, the number of cataract or number of disease people will increase rather than just frequent some visitors. They have around more than 60,000 units in Kerala. So Kudumbasri was a good media to go with the camps. So when our study showed that cataract patients per camp increased to 20 to 25% from 10 to 15%, and also people reporting to cataract surgery and follow-up also increased. So it is an increased sustainability of the program and decreased overburden of the medical team. So now I will come to the few studies, because to get an idea of what is the status of blindness in India. So initially we will come with the LF epidemiology study that is about glaucoma. It was conducted in 1998 to 2003. It actually started in 97, the pilot study. Then the National Blindness and Visual Impairment Survey 15 to 19 and Ravi study of Lakshadweep in 2021. This is our experience about a glaucoma study. That study we screened the whole people for all the diseases. So we got the data of all the diseases. Actually this was an ICMR designed and sponsored study. It was totally sponsored by ICMR. It's a multi-centric study. The ICMR selected 3 districts in India, Ernakulam, Delhi and Ahmedabad. Total population selected was 60,000 per center. Eligibility was above 35 years. So we just calculated 1/3 of the population will be above 35. So 20,000 population per center. 6 areas were surveyed. 3 rural and 3 urban. So each place, each center, 10,000 population was enumerated. Mapping was done by the field workers and statistician. Household visits also by the field workers. This is a vehicle we used supplied by the ICMR for that 7 years. So weekly we used to conduct 2 to 3 camps that we always used to conduct in the nearby places. Maximum distance we allowed was only 1 kilometer from their houses. And vision and refraction was checked. This is a vision drum we designed for that particular study. It was an illuminated drum so that we get a better accuracy of the vision. Then in the camps, all the patients are examined by ophthalmologists. Fundus examined with the direct ophthalmoscope, and IOP was recorded with a Perkins tonometer. All these suspects IOP more than 21 millimeters of mercury are called to the hospital for detailed examination. Angle closure suspects also. This study actually, I was helped by many of the seniors in sitting here. I think starting with Dr. Thomas Cherian, Dr. Freddy, Charles, and Ranjini, so many people helped me in this study. Actually, we provided cataract surgery to these patients to get a more coverage. In the hospital, all participants underwent HFA and repeated if the reliability indices were low, then gonioscopy and dilated examination if angle closure after PBI. Its measurements are taken to increase the participation. We frequently visited, even we visited the houses. But we saw that the coverage was 67.68%. This is the actual coverage. So I was involved in every step. The ICMR was trying to increase it, but we could reach only that thing. But the total number of persons screened was 17,706. To remember, this is the highest number of persons screened in anywhere in India, I think. So the defaulters were very high. The males dominated. I think why this male dominated, most of the people were in Kerala, were not in Kerala. When the list it was there, because of the government survey, some people was afraid that their name will be deleted from the ration card. So they were told they are available. So that is why this low percentage of coverage. Another important thing, we check the defaulters profile. Usually everyone think that the illiterate people are the defaulters. But we will see that illiterate is not that high. The secondary educated people, secondary school educated people, 10.37% out of the 32%. The most striking feature of this finding was the second one, that is not the literate. Literate means the newly literate. That means even after the age of 60 years, they were willing to learn language or learn everything. And that people, the defaulters were very less, 0.37%. Actually, they are very motivated people. And this was some of the study results. Open angle glaucoma, 1.3%. Angle closure, 0.42%. And age, you can see that as age advances, the increase in the prevalence, but after the age of, nearly around the age of 75, again there is a reduction in the glaucoma. So totally the prevalence of glaucoma was 2.03%, and the suspects included another 1.28%. So secondary glaucoma and other glaucomas were in small percentage. Then this data we collected for the cataract also. Bilateral blindness due to cataract, that is below 3/60 vision, was 1.52%. Unilateral was 4%. And prevalence of cataract, that is 618. We just took the 618 as the vision. We found at 16.36%. That is the starting of this decade. 2003, up to 2003 actually, the prevalence was this much. And the most important thing is this data. This is the highest study conducted in India in a glaucoma screening, and this is not published. But for this study we spent nearly 1 crore rupees at that time. Then I will be coming to the present standard. This is a national blindness and visual impairment survey. This survey, above 50 years old were screened. 31 districts in India are selected. 3,000 population per district, and totally it comes to 93,000 people. From Kerala, you know that Thrissur district was selected. The objectives was to determine the prevalence of blindness and visual impairment, to identify the major causes of blindness and visual impairment in India, to determine the cataract surgical coverage in 50 plus population, and ascertain the visual outcome after cataract surgery in 50 plus, to ascertain the barriers for uptake of cataract surgery in 50 plus. So these are the definitions used for this survey. Below 3/60 was taken as the blind. So final study results, above 50 years of age, blindness was 1.99% all over India, and visual impairment 13.76%. In district wise, you can see that Thrissur district in India or the Kerala represented the lowest blindness in India, that is only 1.08% versus 1.99% of national average. In visual impairment also you can see almost a similar thing, but there are some North Goa and Mizoram, on town district in Mizoram is lower than this. Age wise prevalence, as expected, the 80 plus is showing more cataract than any other patients. Definitely the rural people are having more blindness. Causes of blindness is estimated in this survey. This is not the survey conducted by Kerala people, it is guided by the All India Institute. Cataract, like in any other survey, 66, 67, that is the rate of cataract in all this blindness. Here it is 66.2, but the second on, next on cataract surgical complication stands very high, that is 7.2, but you have to remember that after cataract also included in this thing. That is why I think the high percentage. Non-trachomatous corneal opacity 7.4, may not be true in Kerala or South India scenario. When you take the cataract surgical coverage in the population age 50 years, it's fairly a good cataract coverage is there, 93.2, so that's very good. And when you take it Thrissur data, it is below 3/60, 95% is there, so it's fairly better than the All India base. And this is one slide I think we have to give importance. The barriers in cataract surgery. We all think that the financial problem is the main barrier for cataract surgery, but even national survey is showing only 22.1% is thinking that money is the main problem for cataract surgery. So we have to rethink about our packages. In the North India, you see that 25.5% is because of the seasonal things. You know that some of the season they won't go for operations. But Kerala, the scenario is totally different. When you extrapolate this data into our population, that is a population taken on 2017. So you will see that 48 lakh people need surgery. They are below 3/60 vision. But visual impairment, you take that 3.4 crore people requires intervention. And what is the trend which happens all over India? You can see that blindness in 2001, it was 5.3%, but it is gradually reduced to 1.99%. That means all our systems, our packages, programs are working very well. We are achieving the what we are planning. So overall population blindness is 0.36 percentage. So that is not the below 50, not the above 50, it's overall. So that is what was planned for the Vision 2020 by 2020 0.3 percentage. This is almost nearly we are reaching there. Now I will come to another study, because this study I am putting it because of two reasons. Now the government also thinks that Lakshadweep is the best place to study about the newer programs, and we can implement and see the results in Lakshadweep because they are very close to the area. And I thank Dr. B for giving this data. This is a rapid assessment of avoidable visual impairment. Actually, this is a RAVI study. Lakshadweep is only 32 square kilometers. Total population in 2011 census was 64,000 plus. There is another finding that the population growth in Lakshadweep is now the last decade it is only 6.3% compared to last decade of 17.19%. That means some of the people think in the other way around, but there the population is very well controlled now. This is an ideal setting for all these studies. This study was conducted in September 2021 and 5 islands in Lakshadweep were selected. And 2002 people above the age of 6 years. It is different because this is 6 years and plus. So the coverage was 98.5%, surprisingly very high coverage because it's a very defined population and they will be there. So that is the idea of having future studies and all programs analysis in Lakshadweep. Primary objective was almost similar, to determine the prevalence and causes of visual impairment and blindness among the 6 plus population in Lakshadweep. Secondary objectives were to ascertain the visual outcomes after cataract surgery, to estimate the effective cataract surgical coverage in Lakshadweep, to ascertain barriers for uptake of cataract surgery. These all ideas, all objectives were similar to all other studies. Actually, the RAVI study used only a simple method because all these studies are very basic studies. They will take only vision and pinhole vision. So each chart was shown to all the people, and occluder with the pinhole was with the pinhole vision. So this is the way they recorded the vision. So all this were recorded in the daylight outside the houses. Each chart was shown. One kaya or something was used to mark the 6-meter distance. And socio-demographic profile of this study population in Lakshadweep shows 6 to 39 years having 62%. That is an younger population compared to Kerala. So all these studies you have to keep in mind that Kerala is having the most aged population and more ophthalmic patients. So that is a good point to ophthalmologists, but we have to work on that one. 70 plus population was only 4.3%. The blindness, when you take it visual, sorry, here it is visual impairment mainly studied from blindness to visual impairment. So the females in Lakshadweep actually is more visually impaired or more blind. Literacy, again, in Kerala, the newly literate has shown a very active role in all these studies, but here newly literate was not considered. So the illiterate is having the default, having the low prevalence of. Again, the Lakshadweep study also shown that 66.7% of the blindness is due to cataract, and again IOL implant was 97.2%. That means there is a very high coverage with IOL even in Lakshadweep. And this is one separate study they conducted for the case of Lakshadweep. There is an importance for this study because they compare the cases outcome, visual outcome 2021 before 5 years and before that. That means This last 5 years, they have developed and they have operated on their own cases. Kavaratti Hospital got excellent facilities. They wanted to study what is the quality of vision there with their own surgery, and they found that it is equal. And you have to remember that most of the cases were got operated in Ernakulam or in Kozhikode and all. But they are having the same visual outcome, so that means their own surgery is equal. The prevalence was totally 0.41% blindness. So it is comparable to other states. It is an ideal place for any study, and we can implement new programs in Lakshadweep first, and we can analyze what is the impact on that thing. And the last 5 years compared with the earlier studies, the surgery outcome is very good. So we will come to the other part of this thing, the last part of my presentation, how to plan community services in next few years in Kerala. The first question rises, is any need to continue free camp surgery services in Kerala? What do you all feel? In national survey, we found that only 22% of people are having problem with the cost, because the majority can afford the surgery. But still we have a lot of camps in Kerala. So started from 98, so I thought about coming to the latest data. This is the government of Kerala data on the last years, 23-24 financial year data. The government is saying this is the right to information, like I got the message from the right to information method. 2,51,569. That is a total surgery we did in Kerala last year. And if you divide it into 14 districts, it comes 17,970. We take some few districts are smaller, so we take at least 20,000 surgeries per district. Okay. Then I was searching for how many eye hospitals in Kerala. KSOS is not having any data. Anyone having any data? How many eye hospitals are in Kerala? I could not find it anything. So I just tried in Trichy district. This is an incomplete list. So more than 30 private eye hospitals in one district, plus government hospitals in Trichy district. So then I took the data from our own hospital, Eye Vision Chalakudi, in 2023-24. The total cataract surgery was 2,799. So just for a rough calculation, I just took 20 hospitals. If doing 2,000 surgeries, it will come to 40,000 surgeries. So the government data is much less than this. So that is reporting is again there is some problem in this. Then the other information I took was among this 2,05,000 surgery, 50,000 surgery, how many are there in the Karunya Arogya insurance program? That's a free service, no? Last year in Kerala, 92,233 surgeries were done in Karunya programs. That means 36.6% of all surgery in Kerala was operated under Karunya, if you believe that earlier data of total surgery. So we have other programs like a Medicep, ESI, ECHS and other insurances. That all means that most of the people are now coming under some of the insurance, but few are still outside the insurance. But the problem with this Karunya program is we don't know what is the future of this Karunya program. Then come to the definition of cataract surgical coverage, the proportion of people who had cataract surgery compared to the number of people who need surgery. So our Ravi study has shown that 93-95% of the people cataract surgical coverage. So that means our cataract surgical coverage is okay. But these are all based on the data that 618 is taken even for visual impairment. But we are all aware that now the cataract surgery indication is not 618, even 66 is the indication, no? 66, okay. When you take the national survey, Thrissur having 95% in 3/60, but 618 when you take it, 77.3% is the cataract surgical coverage. So whether we have to continue the eye camps or not, but the present scenario is the camp activity is from the 1970s to 2024. The purpose is changing. Now the camp activity has become one of the main publicity program for all private hospitals. So it will continue. That is what I feel it. So what we can change it? Earlier we were doing all free surgery for every camp patients. Now we can do the cataract screening camps, and many of the poor patients are covered under the KSOS program. They can get the surgery done under him. Now there is new program coming. All the people above the age of 70 also will be covered under the Ayushman Bharat. So that irrespective of the their income, everyone can come under the KSOS program. So limit free surgery to the deserving, increase the quality. That is the main thing. We can, there are other diseases which is not that much screened now, like diabetes screening. You know that Kerala is becoming the main capital of diabetes. So we can associate with the physicians and do more cataract diabetes screening. And another important factor is even in the hospital we are missing many diseases on many conditions. So we have to have a comprehensive examination of all the patients coming to our eye clinics. Better school screening program that has improved very well, but still sometimes it is so surprising that even a 15-year-old or 17-year-old child coming with a -3 cylinder all undetected. So we have to increase our awareness programs. So finally, you have to enjoy your profession, because don't look at whether you are doing free cases or paying cases. If you start thinking of all these things, say I am inferior, all these things, then the problem comes. So ego is the biggest enemy of humans. When you allow your ego to control your thoughts, everything you believe becomes an illusion. So you remove your E from your ego, we can go miles. Here I have to thank my wife Rani, because 35 years in ophthalmology, more than 1050 camps, that means 3 years I was in the camps, so she suffered the maximum. Thank you, Rani. Thank you, all of you.
Thank you, Dr. RadhaRamanan. On behalf of KSOS, we are honored to have you as the Oration Award winner, and we appreciate your contribution in organizational level to KSOS and community ophthalmology level to the whole state. Thank you, Dr. RadhaRamanan. One more big applause for Dr. RadhaRamanan for his contribution. Thank you. Photo